Dear students, welcome to R.A.T.S. UG to PG. Names don't matter most, but goals do. Day 8. The question that was asked was, an 18-year-old boy presented with a swelling, moving with deglutition and non-protrusion of the tongue. The probable diagnosis is subaortic basal cyst, thyroglossal cyst, lateral aberrant thyroid, lymph node in the space of Burns. I would advise you people to kindly revise the midline swellings of the neck, which is a theory question in surgery. The answer in this case is thyroglossal cyst. You find that there is a foramen cecum, and through that you will be having the thyroglossal duct, from which you find ultimately the thyroid develops. Therefore, it is connected. The thyroid will be moving with deglutition, but once it is developed, it is removed from this. Therefore, a persistent thyroglossal cyst will be in connection with the foramen cecum. Hence, it will be moving with deglutition as well as with protrusion of the tongue. That is a clinical diagnosis. And the surgery that is done is they have to remove this entire tract, which is called the cyst trunks operation. And histologically, when it comes to us, we give a diagnosis first by seeing a cystic space. The topmost zone is a cystic space. It is lined by a columnar or a ciliated columnar epithelium, below which we will be able to see the thyroid follicles. Therefore, we give a diagnosis of a cystic lesion with thyroid, that is thyroglossal cyst. The next question. An 18-year-old female presented with symptoms of anxiety and palpitation. Her BP was 140/90. No neck mass. Ultrasound revealed an abdominal mass. Please view the history carefully, measuring 5 into 4 centimeters. Surgery was performed and the mass was sent for histopathological examination. So this is the gross and microscopy of the lesion that was removed. Grossly, it was ovoid, showing multiple cystic areas as well as a few solid areas. Microscopically, the bruise structure that I am seeing is the ovarian stroma, and it is showing multiple cystic or small follicles filled with eosinophilic material that is colloid, and it is lined by flattened epithelium. So it is a variant of a teratoma that can be called a stroma ovariae. So the answer for the question is stroma ovariae, which is a specialized monodermal variant of a teratoma. Now, this is what we people are supposed to see. We have seen the thyroid follicles and multiple flocculated ones. What we should not confuse ourselves with is this. So look at this one. This is a normal picture of the thyroid showing multiple follicles lined by flattened cells. Now in the ovarian stroma, when I find this, it is called a stroma ovariae. Also sometimes I can find this in a case of the kidney. This is called as thyroidization, classical of chronic pyelonephritis. And rarely there can be an ectopic thyroid showing a normal thyroid-like tissue. You people should have this in mind. We shall now move on to the next answer. The question is, a 6-year-old boy presented with recurrent leg ulcers. Mild failure to thrive was noted. His hemogram revealed hemoglobin 7 grams per cent, MCV 70 femtoliters, serum bilirubin 2 milligrams per deciliter, and reticulocyte count 8.5%. Look at this carefully. There is an anemia. The MCV is reduced. There is a jaundice, and the reticulocyte count is increased. Even in a child, it will be at the most 6%. So all are abnormal in this case. and the patient is having recurrent leg ulcers. This is classical of either a sickle cell anemia or another congenital disorder, which is probably hereditary spherocytosis. Beta thalassemia has to be ruled out in this case. And a peripheral smear is essential for confirmation. Look at this one. I will not go into the details. There are some cells which are small with no hemoglobinization. The spherocyte is the smallest possible red cell. And to confirm, we can do a test called as Osmotic Fragility test. Look at this. You find that gradually there is an increase in the saline concentration. In this case, you find that even at 0.8, 0.7 or usually 0.65, there is a osmotic fragility that starts in a case of hereditary spherocytosis. Whereas in a normal patient, it will be in a concentration of around 0.5 or 0.4. And this is the explanation which you people will have to go back and read. The spherocytosis is mainly a defect in the cytoskeleton. There are some bands like the spectrin and then the ankyrin, which is cross-linking it to the red cell membrane. Therefore, it is a red cell membrane disorder, about which we shall see on a later date. And I would like you people to kindly revisit this topic. The next answer. All are chemical mediators for increased vascular permeability except. A very simple, straightforward question for which the answer is C5b29. Vasoactive amines, prostaglandins, leukotriene C4, B4 and D4 are all increasing vascular permeability, whereas C5b29 causes membrane attack complex. This is a rather boring but a very important topic which will haunt us throughout. Therefore, I would like you to kindly revisit and memorize this particular tabular column. You have been given the function and the mediators. Kindly go through them. Any number of questions can be asked from these. The thought for day 8 is 1. Thyroglossal cyst is the answer. We will have to go to neck swellings. The references are given over here. And be careful, it is mainly surgery. And the benefactors can be anybody from first year who looks at the development of the thyroid to the final year, who writes the exam, and the CRRI who faces the NEET or next. Stroma ovariae. Obviously, gynecology will be included. 10 teachers and Novak have been my references. You people can go to any book that you like. And the students involved are these. Spherocytosis in hemolytic anemia. It comes in one page of my book, Robbins and Davidson. Benefactors are given over here. And the chemical mediators itself, and perhaps the best reference will be Robbins itself. Second MBBS and CRRI. Kindly go through it. The questions for the next day will be: autosplenectomy is most commonly due to sickle cell anemia, massive myocardial infarction, non-Hodgkin lymphoma, and portal hypertension. Question 35. A 6-month-old infant with cleft lip and polydactyly, extra thumb, was brought to the pediatric OP with complaints of dyspnea. On examination, the child was malnourished and underweight. The laboratory investigations revealed hemoglobin 6 grams, total count is 8,000, platelets 3,60,000, and fasting blood sugar 92 milligrams per deciliter. The probable diagnosis is Diamond-Blackfan syndrome, Fanconi syndrome, Wiskott-Aldrich syndrome, Shediac-Higashi syndrome. I would like you people to kindly visit each of these syndromes and to read up these references. The next question is, The most common disease manifested by an adult in Down syndrome is Alzheimer's disease, congenital heart disease, acute myeloid leukemia, and atresia of the esophagus, which means we will have to revisit this particular topic. The next question is, periodic acid shift, PAS, is used in the histological diagnosis of sickle cell retinopathy, retinitis pigmentosa, Tay-Sachs disease, retinoblastoma. And these answers are given in our classical textbooks. All are true about Schneiderian papilloma except it may be inverted. Malignant transformation occurs in 10% of cases. It is lined by ciliated columnar epithelium. It is associated with human papilloma virus 6 and 11. So, except is the condition over here. The simplest questions are the most difficult. To be continued on day 9.